my gosh, I can throw them up. Yeah. I think the worst one was rat and fish.
All right. So smoking cessation will be pretty quick. There's not a lot of drugs to talk about, which is nice. Let's just talk about smoking quickly. So lots of good stats. Leading preventable cause of mortality. 70% of smokers out there, when surveyed, will say they actually want to quit. So if you work with, you're going to encounter patients that smoke. It's always good to just ask if they're interested in trying, because a lot of them probably will be. 40% have tried to quit in the past year. 3 to 7% will be able to quit and remain abstinent for more than 1 year without the use of any type of aid. So that means cold turkey only works for about 3 to 7% of patients. So pharmacologic assistance is usually preferred in addition to counseling and quit plans and things like that. All right. Smoking prevalence by state. Again, I like my stats. There's some fun stuff. And by country, more interesting information. A nice infographic about how smoking's bad for everybody, right? What things caused by smoking. I think it's interesting, all the different stuff that smoking is attributed to. And then if you actually look at the stats, there's like a large portion of smokers never get anything. They never get cancer. They never really get COPD. And so, like, how do you smoke for your whole life and not even get some sort of obstructive pulmonary disease? But it's possible, I guess. So interesting how some people are really heavily affected by it. A lot of people are, I should say. And then there's a pretty decent chunk of smokers that really don't get significant disease from it. All right, nicotine. So nicotine is what we were talking about primarily today. That's the psychoactive substance in cigarettes, as we all know. It's just one of 4,000 chemicals in a cigarette. It's not carcinogenic by itself, which makes it nice from a pharmacologic aspect because we can supplement the nicotine without replacing and then replace all the junk that comes in a cigarette itself. Nicotine's got a really fast onset, and anything you inhale has a really fast onset. So it's going to reach the brain about 10 seconds after inhalation. Works on the nicotinic acetylcholine receptor subtypes. And if you remember those, they have some interesting pharmacology and how when we talked about acetylcholine and muscarinic receptors and all that type of stuff earlier last fall, nicotinic receptor subtypes actually have some effects on both the sympathetic and parasympathetic nervous system. So you get the like the epinephrine dopamine effect, so increased pleasure. You get that increased hemodynamics and blood pressure. It acts as a stimulant in some aspects. And then you have the effects that cause like GI-related things, so increased GI motility and things like that. So it's kind of an interesting pharmacologically because of those two different opposing forces that tend to both be stimulated at the same time via nicotine. And here's just something listing that out. All right, tolerance develops. Half-life is about 2 to 4 hours. So somebody who smokes a pack a day, you can do the math. Makes a little bit of sense why they put that many cigarettes in a pack. Dopamine response is similar to heroin and opioids. So you actually do get a really big burst of dopamine. Biphasic mechanism that will result in sedative effects following stimulation with higher doses. So initial stimulation is followed by blockade, which kind of causes the follow-up with sedatives, or the sedation effect that can possibly follow it once the drug is out of your body. Convulsions and respiratory failure may occur with extremely large doses. Nicotine's really toxic if you drink it concentrated, and especially if you're a child. So one of the things that people have been upset about with the e-cigs and the liquid nicotine products, the concentrated products that are out there, is if a child happens to ingest it, it can be fatal. So that's been something that we didn't really see before those products existed on the market. Side effects of nicotine, so lots of different systems are affected, right? So you get increased clotting tendencies, bronchospasms, tremor, muscle pains, gastrointestinal effects, all those things there. Central nervous system effects, heart rate stuff, hemodynamic stuff, lots of different systems targeted with nicotine. Lots of different diseases affected too. Again, I don't really think I need to go through all this again, but they're there. This is interesting, I think. It just talks about how your lungs are really will do a good job at cleaning themselves out. So if you actually stop smoking and how long it takes for all this stuff to happen, it's pretty, I don't know, maybe motivating for some people who are smoking. So anyway, let's talk about how we help people quit and what kind of drugs we can use for that. But before we do drugs, we want to use non-pharmacologic interventions. So ask a smoker if they're interested in quitting. There's actually good data out there that says that the more often you ask somebody, the more likely they are to actually try a plan. So little interventions can make a big difference in a smoker. Make sure you have access to adequate resources. So a lot of smokers have tried to quit and fail multiple times even. So have they tried everything available to them? What medications have they tried in the past? Have they tried a quit plan? Have they worked through, does your clinic have something that they can set them up with? Have they tried accountability, things like that? There's a lot of different tricks out there you could try. Think of it as a disease requiring long-term management and follow-up. If your patient is interested in quitting, set a quit date. Usually within the next 2 weeks, you're going to set them up with some sort of a plan in place there, usually pharmacologically and also with some counseling. And then follow up with your patient. Follow up after 7 days and see how it's going. If they know no one follows up with them, they're much more likely to not follow through themselves. Okay, NRT, or nicotine replacement therapy. So the kind of the bread and butter behind helping people quit smoking. Goal, replace nicotine without the health risks. Also decrease the buzz. So the idea is none of these products absorb as fast as a cigarette. None of them have as much nicotine as a cigarette in them. So you can see cigarettes here and plasma nicotine concentration. The fastest absorption is really the gum. Some would argue maybe like there's this nicotine inhaler thing, but that's still, it's not an actual inhaler. You're just still absorbing it in the oral mucosa. And you can see the patches provide more of a slow onset, steady state release. And the gum will have various effects depending on how somebody will use it. And obviously the different strengths will cause different amounts of nicotine plasma concentration. General recommended is that you use a short-acting plus a long-acting nicotine product together. So a lot of people will have a patch they wear daily, and then they'll use something short-acting. So either gum, lozenge, inhaler. There's nasal spray as well, which isn't used very often, but it is an option. And then there's other pharmacologic options too that you can combine with nicotine, which we'll talk about in a second here. Nicotine's pretty much going to be tolerated by most people. Theoretically, there'd be some complications with cardiovascular diseases because it does have hemodynamic effects. However, remember what the person was doing before you prescribed them nicotine, right? They were smoking. They're getting more nicotine than probably what they're going to be getting via their replacement therapy. So is that going to really be a big deal with their CV disease? I don't know. It depends how far down along. Are they a serious heart failure patient, or is it just mild hypertension they have? That would be something to weigh the benefits and the risks on. Let's talk about the patches for a second. So patches come in 3 different strengths: 21 mg per day, 14 mg per day, and 7 mg per day. And so you start with 21 milligrams per day for anyone that uses more than 10 cigarettes a day. So smoke more than half a pack a day, start with the highest patch dose. If you still smoke less than that, or less than 10 cigarettes a day, you're going to start with the 14 and then go from there. So 21 milligrams per day for 6 weeks, 14 for 2 weeks, 7 for 2 weeks, and then you theoretically are done with the patches. If you're less than 10, you would do 14 for 6 weeks, 7 for 2 weeks, and be done after that. Apply once daily. So it's just like any patch. You apply to a non-hairy skin site, rotate daily. They can be kind of an irritating patch, so just rotate the site. You can do it upper arms, back, I think chest and lower back as well. May cause insomnia or vivid dreams. Some people will actually take these patches off at night because they can't sleep when they're on, which is understandable based on nicotine's pharmacology. So certainly an option for people. However, that can result in a really strong morning craving. So just making sure the patient's aware of that and they have something short-acting that they can easily use in the morning, so they don't want to revert to a cigarette first thing in the morning. Short-acting options. So the patch is the only long-acting option. There's no other like oral or anything like that that's long-acting. The patch is your only choice for that. Short-acting gum. So gum's probably the most popular. The gum isn't really like regular gum so don't think of it like that. The basic way to use nicotine gum is you chew it until the nicotine can be tasted, which must have some sort of a distinct taste. I've never actually chewed nicotine gum, so I don't know. But then you cheek and park it so you park it in your cheek and it's going to absorb. You just repeat, chew, park, chew. And that's why you can see, if you go back to this, you can see the gum kind of has this weird, like it's not a clean absorption, right? Because you're cheeking and parking and cheeking and parking. And so it's got different amounts of nicotine getting absorbed at different times. It's just the nature of the product. You can use up to every 1 to 2 hours, so you can actually use the gum very frequently. So it depends on how heavy of a smoker you are. If you smoke more than 25 cigarettes a day, you start with 4. Anything less than that, generally it's recommended to start with 2 milligrams. Acidic beverages beforehand, coffee, juice, and pop, can impair the absorption of nicotine, so we're supposed to avoid those. Aggressive chewing and swallowing of the gum and nicotine will cause nausea, vomiting, and abdominal pain, as you might imagine. Most people don't chew cigarettes and eat them, so they aren't used to ingesting nicotine directly into their GI tract, and if you do that, you can get really sick. Lozenge, it comes as a lozenge too. It's a very similar concept to the gum. You cheek it and let it dissolve slowly. Basically, it's personal preference. Does it taste better to you? Do you like the way the product works better? It's up to you. Same thing. Inhaler's a little bit different. Our smoking cessation people at the hospital love these inhaler things because one of the things they associate with smoking is the behavior of just kind of having that oral fixation. So if you have that mouthpiece you can put in your mouth, it does mimic that feeling of having something there and smoking a little bit, even though you aren't actually smoking anything. In fact, you aren't even inhaling anything. So you breathe it in, and you can try and suck as hard as you want, but the liquid's fairly thick, so it's just going to land in the oral mucosa, and you're going to cheek it. Sometimes you might end up swallowing it too, so it might be a little tricky there. But again, it does mimic that physical action, and you can use 6 to 60 cartridges a day, so you can use it fairly frequently, pretty much every 1 to 2 hours, just like the gum. Nasal spray has the most rapid absorption out of everything, which might be a downside to it. Do we want something with rapid absorption? I don't know. You might want to delay that absorption a little bit so you aren't giving that person that reward system. 1 to 10 sprays per hour. Significant nasal irritation is a compliance problem, so this can be annoying for people to use. I don't see this used very often at all because of that reason. Okay, the other drug we're going to talk about, we're going to come back to our drug Wellbutrin or bupropion, and that is a option for smokers. So just to compare percentages of people quit with the different products out there. So the problem with this is that there's nothing here that has a combination nicotine therapy. So we don't have gum plus a patch, which would be interesting to see comparatively speaking. But you can see that people actually like the nasal spray the most in this particular trial. However, it doesn't really have discontinuation rates or anything like that. But you see they're all fairly similar. The short-acting options tend to be more favorable than the long-acting ones, but then again, if you combine the two, you get even better results. So we'll look at some of that stuff here in a second. Study here from the Annals of Internal Medicine that looked at patch versus the spray. Again, long-acting versus short-acting in different patient populations. So some interesting things to point out, I think, like non-obese patients tended to like the patch a lot more than the spray, meaning there's probably absorption issues once you have more body mass index with the patch, which isn't uncommon for transdermal delivery. Varenicline or Chantix is the newer agent in this area. It's been actually around for quite a while now, but it's kind of got an interesting pharmacology. It's partial agonist on the nicotine acetylcholine receptor. So you produce partial stimulation, but you reduce symptoms of nicotine withdrawal. More importantly, you block the effects of tobacco smoke and the nicotine it would deliver. So you can be on Chantix and smoke a cigarette, and the idea is you don't actually get an effect from it. So it's really the only drug that has that similar property to it. Superior quit rates compared to nicotine replacement therapy and bupropion. Quit smoking 1 week after starting Chantix is the way you start. So you put your quit date 1 week, start your Chantix, and then 7 days in you can stop smoking. I find that a lot of people who do this don't get the effects from smoking anyway, so they naturally kind of stop doing it on their own. Neuropsychiatric effects. Chantix is not side effect free, causes depression, behavioral changes are probably the biggest ones people complain about. However, smoking itself can also cause these things too. Avoid if you have a history of suicidal ideation or unstable psychiatric state. Those are the contraindications to this. Cardiovascular disease, probably a little bit better than nicotine replacement therapy as far as hemodynamic tolerability. Other effects, people get nauseous on it, so recommended to take after eating with a full glass of water. Make sure you get a full stomach when you take it, and it's much better tolerated. Comparison here of varenicline versus bupropion and placebo. Looked at varenicline having higher abstinence rates, but they kind of normalize over time, just like with anything. Once you get further out, you have more people who fail the therapy. We talked about Wellbutrin, aka bupropion, already. Bupropion came out as an antidepressant and was rebranded under the brand name Zyban. It's the exact same drug. So for a while, there were two different products when it was brand name. However, now it's just one, bupropion SR, extended release, whatever you want to prescribe, it's the same thing. Start 1 week prior to your quit day, continue for 7 to 12 weeks longer, usually at least 12 weeks recommended. You don't really have rebound weight gain, which I didn't mention with the other ones, but a lot of the other ones, especially once the nicotine phase is done, people do tend to gain weight back when they stop smoking, which is maybe a reason why they wanted to smoke in the first place. I think there's that thing out there where people think that keeps you skinny or whatever, but in actuality, it's a big trade-off for the other health benefits you're giving up. But bupropion, you could maybe use it as a counseling pearl that you can use this with and possibly gain less weight overall. It's generic. It's less expensive than Chantix. Less side effects than Chantix. It's a really well-tolerated medication. You can combine this with NRT, so it's an interesting synergistic effect there. So certainly can be used together. And you can also combine it with Chantix if you want. Just not well studied. The only thing you can't combine together, Chantix and NRT don't go together, hopefully for obvious reasons, right? The nicotine would just be blocked by the Chantix. However, the other ones will work together. So anything can really be combined with Wellbutrin, because if we remember back to our to our depression lecture, it's basically a dopamine reuptake inhibitor. So it's increasing the circulating amount of dopamine, which is going to help with some of those pleasurable response cravings is the idea behind that. So the reason why it's used in things like gambling addiction, because of its mechanism. So it's a unique drug, and it has a pretty good role to play in here. So certainly think about adding it on. If we summarize, so first things first, most people recommend some sort of counseling as a baseline for anyone wanting to quit smoking, and then varenicline or combined nicotine replacement therapy. Just based on the data alone, those two options seem to have the highest quit rates associated with them. If you have cost issues with varenicline, bupropion, or cost issues with the combined nicotine replacement therapy, believe it or not, a lot of insurances don't actually pay for combined nicotine replacement therapy or nicotine replacement therapy because it's over the counter. So they're like, no, you pay for that yourself. It's like, how much is this person going to save you in the long run if they quit smoking? But we won't get into that right now. So anyway, somebody's like, well, the patches are just too expensive because they're kind of pricey. I mean, not super expensive in the long run, but they're not cheap. So if you're having trouble with the cost, maybe considering just bupropion alone. Again, it's generic and pretty cheap, or a single nicotine replacement therapy agent. If you're compliant but have issues with side effects, either adjust the dose, try going down, or try another option you haven't done at that point. So if you start Chantix, the person's not tolerating it, they're feeling really aggressive or depressed or whatever, maybe try switching to Wellbutrin as an example. Not effective. Have you tried combination therapies? And then what areas haven't you exhausted yet? If your person relapses after they quit successfully, you just try what worked before. There's good evidence that so if they did bupropion, they quit just fine on it. They've been off cigarettes for 6 months and they start smoking again, start them back up on Wellbutrin. That's what the evidence would say. All right, nicotine withdrawal, certainly not fatal, but symptoms: anxiety, depression, restlessness, headaches, increased appetite, and difficulty concentrating. Treat with nicotine replacement therapy. Cold turkey will not kill somebody. It's just really uncomfortable for people to go through. Special populations. Adolescent patients, if you work in adolescent medicine and you have some kids who are smoking, you could say, it's going to affect your athletic performance or your future health appearance. Show them some pictures and scare them on the internet. I don't know what you want to do. Not sure. Nicotine replacement therapy and counseling has been shown to be effective in adolescent populations. Varenicline and bupropion are likely just fine, but not really well studied in that particular age group. Bupropion I'd be much more comfortable with. Varenicline really hasn't been studied in kids, teenagers, I should say. So, I don't know. Maybe someday we'll get there. Pregnant women. The good thing about being a pregnant woman is there's lots of good things, right? One of the good things, as a healthcare provider, you get a lot of opportunities to meet with your patient, usually if they're following up at regular intervals. So that's a lot of opportunities for intervention if they're still smoking during their pregnancy. There's a lot of risks that are listed there. Nicotine replacement therapy. Nicotine itself is not thought to be better than smoking during pregnancy. So nicotine replacement therapy and bupropion have both been kind of cleared for pregnant use if you wanted to go down either one of those roads. Varenicline is not studied in pregnancy. Oh, e-cigarettes. Oh, man. I don't even know where to start with these. So this is kind of like a whole topic in and of itself. Basically, electronic cigarettes or vaping or whatever you want to call it, they aren't FDA approved or regulated. Electronic system, it's going to aerosolize some kind of a nicotine solution. Usually the solution is like a propylene glycol based, some kind of a solvent. So certainly less things in it than a cigarette, right? We talk about 4,000 chemicals. We might talk about a handful of chemicals in this one. But what happens if you vape propylene glycol for 30 years? No one has any idea. So we don't know that. There's questions on if you want to use these for cessation. Is it a better tool than other things? The limited data we have out there shows that there's not really any difference between quit rates between an e-cig regimen and an NRT regimen. So question is there, if you have a patient and they want to stop smoking and they want to use this versus nicotine replacement, and they're going to do, you can't really force somebody to do something, and is this better than cigarettes? Maybe. I can't really say that with a guarantee. I mean, I would like to think yes, but at the same time, there's a lot of issues with these. So just as a side note, there's a lot of controversy with this in the public right now, and I think it's because of child use, right? So we have these, I don't know if I would even call them companies, but there's places that are selling, flavorings with these things, and kids are using them, and they have non-nicotine versions of them, right? So kids can buy them in like bubblegum flavor or whatever it might be, and vape the bubblegum solvent without the nicotine in it. But how do you know they aren't using a nicotine product? And how do you know they aren't going to start using the nicotine? I mean, it's obviously a marketing scam to get them to use a nicotine product in the long run. That's what these companies are designed to do. They want to get people hooked on their product. No question about it. Now, how they're going to do that is right now kind of running rampant because the FDA is not doing anything. However, I believe there's going to be some fairly heavy-handed legislation coming through sooner rather than later, and restrictions on what they can do. There's already a pretty significant proposal that I think was shot down, but we'll see if it comes back around. But it was about limiting it to certain shops, so places wouldn't be able to sell it unless they were licensed for it. And also you would eliminate any type of flavoring that wasn't basically cigarette smoke flavored or mint flavored, I think were the two options they'd give it. So it's eliminating all the fruit flavors and all the other things that people like about them. And interestingly, the data we're seeing now is kind of cool, like it's cool and sad, but for adults who use them, you're seeing that the adult reasoning is more to get off cigarettes, right? They're switching to, adults aren't just, like me, I never smoked in my life. I'm not going to pick up an e-cig and start using it for the hell of it, right? So the adult's going to smoke, and then they're going to think about this as maybe a better option, and they're going to go to that. A kid is going to start doing it because they're seeing that children who start doing it are actually much more likely to start smoking cigarettes after they start vaping. Interesting enough. I mean, I didn't think of that would come out, but that's been a pretty clear trend that they're seeing. So where adults are using them for the opposite way, kids seem to be trending onto cigarettes from e-cigs. So that's why I think the public health community is getting a little bit up in arms about these things and wanting to put some regulations on them and kind of pump the brakes on this whole process. But I think it'll be interesting to see how this all shakes out. It's kind of a hot button issue right now. A lot of public places do ban these, the same as cigarettes. They're treated a lot like cigarettes as far as like restrictions go in places, but certainly a different product overall. So that's all I have to say about that. Any questions on smoking cessation, or I could take questions on psych in general. I'll post a case today, psych cases. Oh, and the marijuana thing, I'm sure you guys saw that on the website. Just get that done by the deadline. Medical cannabis, I should say, is maybe the more correct term. Big topic right now. I don't want to really do a lecture on it because it's a lot to talk about, and I think there's a lot of interesting social stuff out there, especially for you as prescribers. So I think it's more interesting for you to do your own research on that, but certainly an important piece in today's society to consider. So give it some thought and look into those resources, and entertain me in your response.
Just trying to